Hello, everybody, and welcome. I'm Claudia Hammond, and I'm the presenter of All in the Mind on BBC Radio 4 and of Health Check and the Evidence on the World Service. Now, those last two are both about global health, so we've been very busy. So I must say, I'm delighted actually, because I think I'm on something like my 58th or 59th, I'm slightly losing count, program on COVID, and I think I have a few more to come. So it's actually lovely to be talking about something different this afternoon, and talking about a topic that is so interesting as well, and so important. So we're here to discuss whether or not it would be a good idea for psychologists in the UK to have prescribing rights. And it's been fascinating actually reading the arguments about this, and I have to confess it's one of those issues where I read one side and think, oh, good point, and then I read the other side and think, oh, good point, and that I completely flip-flop. So I genuinely have no axe to grind on either side, which is why I've been invited to chair today. And I've not been involved in organising the event or inviting speakers. I'm independent of the BPS. I know passions can run high on this topic, which I hadn't completely realised, but that shows what an important topic this is. And so I'm very keen that today we have the chance to explore some of the issues around psychologists prescribing, and more importantly, give all those of you watching, which is lots of you, the opportunity to ask the questions you would really like answered about this, and to ask what you really want to know about it. Debates, I think, within professions are always interesting, but of course what really matters at the end of the day is going to be whether giving psychologists the right to prescribe will make things better or worse for service users. So I'm very pleased as well that this perspective is going to be covered. So as we go, do be thinking of what questions you would like to ask and putting those into Slido. You've probably seen on the slide just now that the code number is V123. So if you have questions, do put them there. You can also, you've probably used Slido, but you can also upvote other people's questions. So if you see a question you really like, give it a tick, and then if lots of people do that, then we can be sure that I can put that question to people. You can put questions to someone specific if you want to, but don't worry if you don't, because I will just put them to the appropriate person. So what's going to happen is this. In a moment, we're going to hear from the chair of the BPS practice board, who'll be explaining the role of the BPS prescribing rights task and finish group, and where they are in the process, and what that long title means. And then briefly, the chair of the group and three members of the group, including a service user and a psychologist in the US with experience of prescribing, will just introduce themselves, and then I will ask them some questions, some general questions about what they think about it, and then start putting your questions to it. So you know, my job is to make sure there are plenty of time for questions. So to those of you on the panel, obviously, if you are talking for a long time, then forgive me, I'm interrupting. On Zoom, interrupting always looks particularly rude, because there is no way apart from, you know, talking over people. So forgive me if I do that, but my job is to, of course, ensure that all the views are heard, and that we have a balanced discussion about this. And I really do want to hear all views on this. So if people can try not to interrupt each other, that would be great too. Who knows, by the time we get to 5:30, I may even know what I think about it. Not that I'll be sharing that, but it will be interesting to find out. But first of all, we are going to hear from Alison, who is chair of the practice board, who's going to introduce things.
Thank you, Claudia. So just to set this in context a little bit, in 2016, NHS England asked for the Society's views on psychologists being added to the list of non-medical prescribers. The Society had no view, nor did it have information on which to form a view, so under the aegis of the Practice Board, a task and finish group was established in 2018 to gather the information that would enable such a view to be taken. This work is not yet complete, and therefore the Society still has no view. A great deal of work has been undertaken and is available to be examined on the Society website under /prescribing rights. The Practice Board asked for this opportunity today for any remaining members who wish to engage with this process yet to do so. As a result, the email address to receive your further feedback in respect of this event or the discussion paper or any of the other information remains open until the 1st of October, and you will receive an email to both the website link and that email after this event. There were almost 360 members, I believe, registered for this online event today. Some of you have contributed to the information gathering, and some of you have put in a great deal of volunteer time getting us to this point. Everyone's participation is welcomed and appreciated. At times, passions have been aroused amongst members who hold differing views on this question. I would like to draw our attention to those values that we hold in common at the start of this event. Each and every one of us wants to use our knowledge, experience, and talent to do the very best for the patient or client base that we serve. We are a broad church, so we should not be surprised that each of us, having travelled to the point where we have arrived today by our own route, that we should find a range of differing points of view amongst our colleagues. Today is not intended to be a binary contest to find out who is right and who is wrong. In such a contest for right and wrong, there will be no winners, as conflict after conflict around the world has amply proven. Instead, we have an opportunity today to seek to better understand the nuanced positions against and for considering the adoption by some psychologists of the responsibility of holding prescribing rights. As chair of the practice board, I'm putting my faith in the commitment to good practice of my colleagues to illuminate this question with their knowledge, experience, and wisdom, and to help enable us form a view in the coming weeks. We'll now see a short animation.
The British Psychological Society are exploring the idea of whether it could be helpful for some psychologists to have the opportunity to develop the competencies required to prescribe medication. NHS England asked us what we think, so we set up a group to look at this in 2018. We know some of you are confident about your views on psychologists prescribing, but others have asked for more information. We all know that medical doctors and dentists can prescribe, but did you know some other professions such as nurses, physiotherapists and paramedics can also have prescribing rights? Whilst psychologists can't currently prescribe in the UK, psychologists have been safely prescribing medication in America for almost 30 years. Non-medical prescribers have to complete specialist training to make sure they have the right knowledge to prescribe safely. They need to have at least 3 years of post-qualification experience in the area that they work in, and supervision from someone who is experienced in prescribing to get onto the training course. As well as this, psychologist prescribers would need to work within a multidisciplinary team or practice network. This means that if there were any medical needs, a specialist would be at hand to support the psychologist as they do for other non-medical prescribers. When someone goes to see a psychologist prescriber, they would still engage in the same collaborative assessment and formulation as they do at the moment. But there would also be the option for the person to talk about including or reducing medication alongside their psychological treatment. Non-medical prescribers can only work within their area of expertise. This means you couldn't go and see a psychologist prescriber for antibiotics when you have tonsillitis, but you might see one to help with opioid detoxification in a drug misuse setting. We've listened to a lot of people already, and there's lots of passion about prescribing. Some psychologists worry about how it might affect their professional identity. Some psychologists feel it's a natural evolution for the profession. Some people with lived experience can't wait because they won't have to tell their story twice. Some people with lived experience worry about trusting their psychologist if they talk about medication. It's all about choice. Only psychologists who wanted to and had the right experience could choose to do the training and have prescribing rights. Whatever the final BPS position is, we cannot grant prescribing rights to psychologists. New prescribing professions are approved in Parliament following a robust process which focuses on the benefits for service users. We are still engaging with the psychological community, other healthcare professions, and anyone with a view about whether some psychologists should prescribe. This period of consultation is due to close on the 1st of October 2020. We have a webpage where you can find more information and the consultation document and frequently asked questions, or you can email us at practiceteamgroup@bps.org.uk.
So if you already have questions that you want to ask, the way you can do those is by going to slido.com. You go to slido.com, and as soon as you get in there, you need to put in the code V123 so that you ask a question at our event and not some other of the many millions of events no doubt going on at this moment. And so you go to V123 once you're in slido.com, and then write your question in there. Once there are questions on there, there is also an option for ticking the questions of other people's that you like, and then you're kind of voting for those, and you're upvoting them, if you like, so that they rise to the top, and that we answer the questions. I put the questions to people to answer that people would really like to hear. Now, the people who will be able to answer your questions, I'm going to let them each introduce themselves to you, starting with Rebecca.
Hello, good evening, everybody. My name's Rebecca Courtney Walker. I'm a consultant clinical psychologist and associate psychological services director for a large mental health trust and learning disabilities trust in the northeast of England. And I have been chair of the group since it started. So unfortunately, one of our panel members has had to drop out this evening, Professor Christina Richards. I am needing to step up, and rather than being the person introducing the event as our chair of the practice board has, I've need to step into the panel. But my role very much through the process has been to stick with the core purpose of us trying to be independent, stick to the facts and the evidence, and ensuring that the group stay in line with making sure we're collecting equal evidence for opposing views and favourable views. So I'll be trying to represent the work done by the group so far this evening.
Thank you for that. And Cheryl, I wonder if you could introduce yourself. You're muted at the moment, I think.
There you go, sorry. Yeah, hello there, I'm Cheryl Blake, and I am an expert by experience, and I'm part of the Task and Finish group, and I'm based in the northeast of England. And
Peter, could you introduce yourself?
Hi there, I'm Peter Kinderman. I'm Professor of Clinical Psychology at the University of Liverpool and a practicing clinical psychologist. Recently, in fact, retired from the NHS after 30 years of service, I think, and former president of the British Psychological Society. I joined this Task and Finish group a few months ago because it was suggested that somebody who's expressed concerns about the process should perhaps join the committee in order to make sure that disparate views and perspectives were included. And that's about me, apart from, I suppose, one other thing to share, which is relevant to this, is that I got an email this afternoon saying that I've been appointed to the NICE guideline panels for the treatment of depression in adults. So that's relevant to this because of the role of prescribing as a common frontline treatment for people who are depressed.
Yes, interesting. And Elaine, could you introduce yourself, please?
You ready?
Yeah.
Okay, I don't know if you could see me or not. Hello, I'm Elaine Levine, and I want to thank you for inviting me to join this important discussion. It's always a pleasure to feel that we're connecting across the oceans with our common concerns. I'm a psychologist in New Mexico. I was a faculty member at New Mexico State University for many years, and then took off and went into private practice full-time. I'm the first prescribing psychologist in the first state in New Mexico, to get prescriptive authority, and hoping I can be helpful in answering any of your questions.
Yes, it would be great to ask you a question first, actually, about, so you say you're the first prescribing psychologist. So what does your role consist of, and where does prescribing come in practice? What do you do? How do you use it?
Well, I'm in private practice, as I said. So I integrate it into my work with my patients. I don't separate it out from the other work, which I think is a real strength of being a prescribing psychologist, is that I see the patient frequently. I'm in a position to really make sure that they're in agreement about the medication, and that we very carefully monitor and make sure that we're using the right medication. I use my psychological skills to stay attuned to varying issues in a patient's life. I like to think it's a psychobiosocial model where the patient's perception is, and needs and wants are central, and that they may change over time. And as a consequence, the medication needs to change over time too.
And so what advantage is there, though, for the client in having you prescribe their medication rather than a psychiatrist or a doctor, as might have happened previously?
Okay. I understand that your situation is somewhat different there, but in my country, psychiatrists, for the most part, adopt a very strong biological model. And for the most part, their practices are centering on medication management. I integrate the medication with working with my clients on a very consistent basis, because I have various skills besides understanding about medications. I feel like I can use a minimum of medication and thereby minimize the side effect difficulties with medications. So I think that's a great strength. But another aspect is that I think psychologists have the sensitivity to see that when there's difficulties around the medication, it isn't that the patient's being difficult or non-compliant. There's something that needs to be understood between the practitioner and the patient. And so because we are there for our patients in a holistic way, I think we're best able to provide quality of care.
Thank you. And Cheryl, I'd be interested to know your perspective here. I'd be interested to know what you first thought when you first heard about the idea of psychologists prescribing, and what your views are on whether that would help you or not.
To be honest, I didn't actually realize that psychologists couldn't prescribe. It was just an automatic assumption to me. And I was really interested in this because I thought that they would be able to prescribe. So I was really interested in looking into it further as to why they weren't already being able to prescribe. And ever since I've been involved with this, I've just been continually more and more just thinking, yes, this is what needs to happen. Because for me, I think a psychologist can kind of get to know you on a different level slightly. And I feel like that would be more interesting to be able to work alongside, say, the psychiatrist, but possibly at the same time. It's not to say that these things need to be separate. But I just think they would have a different viewpoint because of the way that they look at the mind differently, and might possibly be able to give either a better medication or one that would go hand in hand better with the prescription that they're giving them of, like CBT or whatever.
And would you have any concerns at all that they, haven't had full medical training, are not doctors? Would you be concerned that they would know enough about medication to be able to do this?
I mean, if you were to just say, yes, okay, you can prescribe, obviously I would be concerned about that. But from the research that I've been involved with and looking into myself, that's not the case. We will be looking into extra studying, and it's not for everyone, and it's if you really specifically want that, so therefore that passion's going to be there, and you're going to want to learn as much as you can to be on the same level as the psychiatrist, and you will be able to have that education and qualification as well, so you will be at the same level, and it will be safe to be able to prescribe prescriptions, and therefore that would make me feel safe as a patient.
Interesting. Peter, let me bring you in here. It's interesting, this theme that's already coming up of how psychologists might actually bring something extra to prescribing, that they see things from a different perspective and will take maybe, a less biological model of things. What would you say to that?
Well, I think that there's some value in that. I think that psychologists do indeed have a very different perspective on what it means to experience the problems that are commonly labelled as mental disorders, mental health problems and so forth. And even in that language, you can see how psychologists can think very differently to other members of the clinical team. I think that I'd go along with that so far as to say psychologists, if they were prescribing, one would hope would retain from their professional background a different perspective on the art of prescribing. And I would hope that that were true. But of course, psychologists, when they bring that perspective to the care of somebody who's suffering from significant problems that are affecting their mental health, bring a lot more than that. So it's not just the perspective on prescribing, it's the perspective on a whole set of attitudes towards what these problems actually are. One of the things that Cheryl said was that, in a sense, we'd bring ourselves up to the level of psychiatrists, and in some ways that skill set is there. But if that were true, then that's also coming with the danger that we would see medication as, for instance, the treatment of a disorder. We have antipsychotics, in other words, compounds which are marketed as being specific remedies for a thing called psychosis. We have antidepressants, so medication that treats depression. And all of that signals a mindset of what the substance of our work is, which is profoundly different from a biomedical perspective. In the teams, in the multidisciplinary teams that should surround anybody who's suffering, anybody who's seeking help, and indeed in the multidisciplinary teams that are supposed to predicate the work of any independent prescriber. So we're not supposed to be independent prescribers in some future vision, working alone in private practice. The legislation we're promised, legislation slips, especially with some governments, right? But legislation is promised that we work in multidisciplinary teams. And in that multidisciplinary team, there are different perspectives on the formulation, on the care, on prognosis and so forth. And the role of the psychologist isn't only to prescribe medication with a psychological perspective, it's to bring a psychological perspective that has a fundamentally different attitude. Now, one of the concerns that I have about this is that every other time that we've seen people use medication as an adjunct to some other intervention, it skews, as Schafstein, who's the former president of the American Psychiatric Association, said, it skews things towards a bio model. The drugs companies make billions of dollars of profit out of marketing, for instance, selective serotonin reuptake inhibitors, a drug that blocks the reuptake of serotonin, as antidepressant drugs. It comes from a diagnostic background, it comes from a biomedical model, it comes from an explanatory framework that I think is not necessarily wrong, is part of what should go into multidisciplinary team, but it is not the perspective that psychologists bring. So yes.
That's a really interesting point. I'd like to put that to Rebecca actually, because I think that's interesting. Is there a risk that it fundamentally changes what psychologists do and why psychologists are different from psychiatrists and why they can bring a different perspective?
I think what I'd say is psychology as a profession in all of its broad divisions has changed over the last decade. It has not remained the same, and alongside it, so has healthcare. I mean, I agree with Peter that it would be vital that we would keep to our core kind of perspective as psychologists, as a profession, which is our core training, which is why the group were very keen from the start that there would never be any intention for prescribing to be something that would be considered within somebody's core training. It would have to be something that was completely optional, and something that would be done post your qualification and post having several years of experience in that. I actually think Peter in some ways is underestimating the integrity of our profession, actually, in saying that by becoming prescribers that we would kind of fall in and become mini psychiatrists potentially. I have a different view in that I am a non-medical responsible clinician who looks after people who are detained under the Mental Health Act. There's relatively small numbers still across the UK. But what we found with that is that these roles that were traditionally reserved for psychiatrists as a responsible medical officer, that there was a lot at the time, there was a lot of anxiety that this would kind of take something away from psychologists and make them less psychological and get them to buy in more with this kind of very biological model. And in fact, in my experience and experience of working with colleagues, it has been quite the opposite, in that the individuals we are looking after actually get a predominantly psychologically formulation-driven model of care as the overarching model. You still have a medical AC there for prescribing alongside all of the other professions in a team, but it has not made psychologists turn away from their core beliefs. And I think the other thing is, the key with this is the devil is in the detail, really. And I'm aware that for each profession that has become a medical prescriber, the HCPC and the Royal Pharmaceutical Society have been very rigorous about what regulation means, and I wouldn't expect anything different if psychologists decided to do this. So the other thing is, I think that, as Peter says, there has been a great increase in prescriptions of certain medications, including selective serotonin uptake inhibitors. But the other thing that we're forgetting here is that psychologists or any other profession who is an independent prescriber has the right to prescribe, but also the right to deprescribe. So there would be an opportunity here, a bit like Cheryl talked about going to see somebody, and they would have the option of having a psychiatrist or just seeing a psychologist. And we've seen this in nurses as well, who are already successful non-medical prescribers, where somebody can be having some therapeutic intervention, and it's an opportunity, like Elaine has said, to carefully monitor for withdrawal and to support somebody therapeutically on their journey of recovery, really.
Cheryl, I think it's an interesting point you brought up there about choice. Cheryl, if you'd been told before, I guess before you'd become involved and knew more about this, that you had the choice between whether to see a psychologist or a psychiatrist, would that make a difference? Would you have gone for one or other, or known much about the difference?
I would have gone to a psychologist if I had the choice, because I feel that they sort of are much more holistically based and more interested in the person rather than the medical, give them medicine side. I know that's not necessarily what psychiatrists are like, but on a kind of just low sort of level, that is what they're known for. They could just give you meds and a psychologist will talk to you. I would rather have someone talk to me, and if I needed some medicine to help me along, then they would be willing and knowing which one would benefit me, rather than I just go to a psychiatrist and they'll give me some medicine. I mean, as it is, I go to the doctors, and in the past they've tried to throw medicine at me, and I've actually said I don't want it. I would rather someone talk to me. And that is why I would rather have a psychologist. And if I could have a psychologist who was actually also had the medical science behind them on the medicines that they could give me, I would feel more confident that it would be the right medicine for me.
That's interesting. And on this whole question of identity, Elaine, have we been discussing whether it changes the identity of psychologists in some way, and sort of, you know, might make them mini psychiatrists and change which model they are encouraged to lean towards? Have you found that it has changed the identity of psychologists at all, being able to prescribe?
That's a complex question. I think Peter is bringing up a good point. I think that's the risk, that there's so much pressure to just prescribe. And in our state, the pressure is magnified by the fact that there were so limited in providers, especially people that can prescribe. I'm happy to say it, for the most part, hasn't happened. I can't say that it never happens, but I attribute the fact that in our training, we really emphasize, you're doing this because of a quality of care issue. You are a psychologist first, and we organize the training, you know, around that concept. And I think that helps a lot. The other thing I'd like to point out is that even though that's a risk, there's so many benefits. I think we should face that and handle that, because these medications are everywhere. And as a psychologist, I believe it's gotten to a point that everybody ought to know about these medications if you're practicing, because you never, if you don't, then you don't know who you're seeing, if it's a medication side effect or just exactly what you're seeing. So I think this knowledge base has become increasingly critical for all, you know, providers. And of course, once you get the knowledge base, then you want to be able to use it. And I will tell you that I think some of the most important work I've done since I've learned about these medications is when I've been able, in a more sophisticated level, to recognize when somebody really has a biological disorder. I can discriminate it better, and to send them to a specialist, and to recognize when what I'm seeing is a side effect of the medication, maybe a delirium or other kind of side effect. And so the prescribing is just part of more holistic care, taking that much, you know, responsibility. And I can't, you know, I think Peter raises a big issue that we have to address. I think it can be addressed by how the laws are written, and also by how the training is conducted.
And we have some really interesting questions coming in, and one of them is related to that, which I'll put to Peter in a moment. But before that, there's a couple of things that are sort of the basics about what might be happening, which Rebecca, I think you might be best placed to answer, which is what were the reasons that the NHS gave for asking whether psychologists would like to have prescribing rights? So I think maybe it's the government who asked that. And also, would it be only clinical psychologists or other psychologists as well, Rebecca?
Okay, the government asked the question. The question absolutely did not come from the pharmaceutical industry. I want to make that very clear. And also, I'd like to make clear, because people have asked whether any of the members of the Task and Finish group have any links or conflicts of interest associated with the pharmaceutical industry, and I can absolutely categorically say that they don't. In terms of who this is targeted as, we basically looked at anybody who's a practitioner registered HCPC psychologist, because HCPC is currently the regulator for all non-medical prescribers. So it would regulate any profession, including our own, should that happen. And so when we're talking about, you know, people could start doing things that might not be professional, it would be very quickly, you know, if somebody did that, it would be flagged up with the regulator, and, you know, somebody's prescribing privileges would be stopped irrespective of your profession if you're breaking the guidelines. So in terms of which branches, what we did was we thought about, you know, things like, should it be masters, should it be doctorate, and then we thought, you know, obviously on our different branches, they all often will have different levels of qualification. So some branches have doctorate level qualification to meet HCPC registration, some have masters. What we'd be saying is, it would be absolutely not available to anybody who cannot meet the criteria for HCPC. So we're not talking about undergraduate psychology students who've just come out of university from an undergraduate degree. What they have done so far is a range of competencies, this is something that would only be explored if the society wanted to go ahead with it, because obviously there's a lot of work developing a competency-based framework. We already have one to follow from the Royal Pharmaceutical Society, but I guess it would be mapping that onto how would that look for psychologists? Where would the knowledge gaps be? What would the necessary training need to be that would match other professions that have got that, alongside meeting the standard one set by the Royal Pharmaceutical Society.
Yeah.
So in theory, any practitioner, HCPC practitioner, psychologist could, as long as they meet the right competencies.
Yes, so they'd already have to be meeting those competencies in order to be able to undertake the special training to do this. We've got lots of other questions coming through. Peter, this is one which I think you'd be good to answer, which is, what do you see as some of the potential negative consequences for both for psychologists and for service users? Let's start with service users. Could you see actual negative consequences for them if psychologists could prescribe?
Absolutely, and I think, you know, without being rude, I think people have already highlighted in this debate some of the negative consequences. So a couple of years ago, Tom Insel, who is the head of the NIH, I think in America, NIHR, said that 20 years of research and $20 billion looking for biological disorders of the brain underpinning mental health problems was money down the drain and wasted time. So that was the head of biological research into mental disorders. And what we're hearing is, well, it's okay because a psychologist who's done some independent prescribing training can diagnose biological disorders and then assure that they're treated appropriately. That worries me. If that were true, Tom Insel is wrong. But equally, if that is true, then the diagnosis of biological disorders is quintessentially a matter for our medical colleagues. Okay, so that worries me. We're drifting into mission creep. Second thing that worries me is, at the moment in the UK, it's worse in America. It's worse in America. And, you know, to be honest, when people come on and say, this is what we've done in America, I watch the news. I'm not entirely convinced that copying American healthcare is good for service users. On the whole, if something's done in America, I probably think we should in Europe do the opposite. And I use the word in Europe advisedly. So mission creep, worry. Secondly, what happens to service users? The British Medical Association and the BMJ in editorials, the Royal College of Psychiatrists today published guidelines on how to help people withdraw from antidepressants. All of those people, the Public Health England, all of those organisations are worried about the vast numbers of people taking psychotropic medication, pain medication, medication given to kids diagnosed with so-called ADHD, antidepressants, antipsychotics. People who reside in care homes are taking large quantities of antipsychotic medication that's harming their functioning. The British Psychological Society, when I was president, signed up to a charter called STOMP, which was to try to reduce the use of psychotropic medication in people with learning disabilities and people living with dementia. 17% of the population in the UK are taking regular psychiatric medication, and pretty much everybody thinks it's a bad idea and we need to reduce that. One of the psychiatrists on Twitter who I engaged with pointed out that it really isn't difficult to get a prescription for medication. What's really difficult is to get referral for psychotherapy. And the question was, what the hell are the BPS putting their efforts into? So if we have more people on dependence-forming medication, that is, I think, a bad thing. Around the edges, right at the edges, you can think that there are possibly some people who find it difficult to find a medical prescriber who can give them medication. But the vast weight of the balance is that far more people are taking more medication for longer than they need to, causing them physical damage and impacting on their mental health. And making that pathway wider and easier has to be bad for service users. At the same time, if the one profession that should be championing social and psychological responses to distress is diverting its attention to arguing that we should move towards a biomedical response to distress, that can only take us away from what it is that people are calling for. And again, this afternoon, we've had people saying, oh, well, if I had the choice, I would have wanted an alternative to medicine. If I had a choice, I would have gone for somebody with a different perspective to medicine. If I had a choice, I would have gone for somebody who would listen to me and talk to me. So I think there are real dangers if what we do is to say, all of that's the pressure, or that's the negative pressure because there are people whose brains are being damaged by overprescription. BMA, British Journal of Medicine, Public Health England, select committees.
Let me put that to Elaine.
Moving away from psychotherapy towards medicine harms people.
Well, let me put that to Elaine. If psychologists can prescribe, is there then emission creep that then results in more medication being used and less access to talking therapies rather than more?
I absolutely disagree with that. And the point I was trying to make before is that we need a broad range of knowledge, and to say psychologists should not learn about biology is as absurd as saying that, you know, everything's biology. And I think the best way I can explain is to give an example. Even in my training, I was sitting with a psychiatrist, and this patient was saying his handwriting, he couldn't make the letters bigger. And the psychiatrist said, actually the psychiatrist said, that's a side effect from the medication. And I'm reading, and I've never heard about small handwriting being a side effect of medication. And indeed, when we sent him on, and he had an EEG, he had a seizure disorder. Now, I think that added knowledge, listening to him, really listening to him, not just assuming it's all medication. I heard him say there was a problem there, and I didn't think it was the medication. I can think of other examples where the fact that I knew more about the biology, not that I gave that the primary significance, but that I knew more about it, helped me recognize that there are some times when someone is physically sick and it's not being addressed because they're not being looked at holistically. So I could give you many examples, and that's what my answer is to that. I think to take what I said and turn it around and say, oh, you're trying to act like a physician. No, I'm not. I'm listening like a psychologist with an extra level of sophistication.
Are there occasions, sorry to interrupt, are there occasions, Elaine, where you have used your power to prescribe to deprescribe? So to help people take fewer medications or come off medications?
I do that all the time. I mean, I would say that's a frequent part of my practice. I used to see children, and across the board, that's where I'd start. We have a real problem in our country that the underserved populations and minorities tend to get treated with the children with antipsychotics just to calm them down, whether or not they're, you know, really deserving of that. and when it's more a psychosocial situation. So strongly with children, limiting any medication with children, but many, many times I have found ways to help patients get off of addictive medications by using good behavioral management, get over needing tranquilizers, for example, because they're so anxious, or using good CBT to help them go to sleep, and so that they don't need to take other medication for insomnia. And I would say keeping the use of antipsychotics to a minimum, because the side effects of all of them are so significant. I hope that addresses.
Thank you. And Rebecca, you had a point you wanted to come in on there.
Yes, I mean, it was really I suppose there are some things that are unavoidably biological: dementia, learning disability, autism, delirium. And it's often forgotten that, what we're talking about here isn't just mental health. We're talking about a much broader range of individuals, given the broad range within our profession. What I would say is, rather than Peter's point that it has increased prescribing, having non-medical prescribers, the evidence is that it's decreased. I think that, the government, from a public health perspective, Peter has already said everybody's scared that there is overprescribing. And also, from a very practical viewpoint, it's an incredibly expensive bill to the government, actually, as well as to people's health. All of the cardio and metabolic side effects and things, and quality of life and disabilities in society. So it's in everybody's interests, especially the service users, to not be on so much medication. So an example is that, for example, when physiotherapists got prescribing rights, there was a pilot done, and it's been thoroughly and properly evaluated by the government, where instead of going to see the GP, a person with a musculoskeletal condition would go to a first point of contact prescribing physiotherapist. And what they found was, because that person was meeting the physiotherapist, who is primarily physiotherapist, secondary prescriber, they were initially getting relief from seeing that professional. And they found nationally the prescription of opioid pain medication reduced by 12%. Peter mentioned STOMP, which is around overprescribing medication and learning disabilities. In the paper, one of the individuals that was interviewed as part of the work was a non-prescribing pharmacist, and there is actually a growing national shortage of psychiatrists. This is actually well documented in papers such as the Health Education in England document about the Centre of Workforce Intelligence did an in-depth review of psychiatry, and you knew from a lot of people with mental health officer status retiring at 55, and they reduced numbers about 13 years ago. So what they're saying is the supply for chain for people who are having needs that within their mental health is going up, but the supply of a potential profession to address that is actually going down. So what we found in the Northeast is actually we went through a very difficult period recruiting psychiatrists. I think it's actually a national difficulty. And as a result, what they've done now just be innovative to get additional prescribers. So we had a pharmacy prescriber, and what they did was they took on a caseload of individuals, worked with a psychologist. They were doing something called positive behaviour support, and as they did, they were reducing people off this medication very
So I'd like to, sorry to interrupt, I'd like to put a point to Peter on this, on reducing medication, because it fits in perfectly with a question somebody watching has asked, which says that many psychologists would like to be enabled to reduce prescriptions. So in what way is being able to do this incompatible with the profession? Wouldn't that be good for psychologists to be helping people reduce their medications?
I think it's great to reduce medication. I think that's an aim of the Royal College of Psychiatrists. They published guidelines, like I say, today for how to reduce medication in the case of antidepressants. The British Psychological Society, along with a range of other bodies, published guidance for those in the psychological professions for how to achieve exactly that. And so far, both Rebecca and Elaine have talked about one of the principal ways that you do that, which is to offer alternatives. So both Rebecca and Elaine said, look, here's some examples of people with various kinds of problems. They're taking medication. The aim is to reduce medication. So we as psychologists offer alternatives to medication. And, you know, maybe I'm missing the point here. Actually, I'm not missing the point. That was a rhetorical game. I know exactly what's being said. And what they're said is, we would like to offer people things other than medication, but we want the right to prescribe people medication. Right. So it doesn't follow. The way to avoid medication, the way to get people off medication, is to help people get off medication and to offer them alternatives, not to prescribe medication. The second point to be made here is that one of the things that's frequently said about this is that psychologists can prescribe and deprescribe. But of course, if the prescription that we're talking about has been issued by another professional, the prescribing psychologist can't change that professional's prescription without consultation with that prescriber. And if the answer to taking people off prescription medication given by another professional is, and should be, open a conversation with that professional, great, all for it, let's have a conversation with the professional. So the answer to getting people off medication is have a conversation with your colleagues. The BPS and the Royal College of Psychiatrists have produced guidance for that. Excellent, great, 100% support it. Secondly, persuade your colleagues to reduce medication, and for you as a psychologist, offer the alternatives. That's actually what everybody has said, and then they've added the bit, oh, by the way, can I have the right to add more prescriptions, please? You can, of course, deprescribe your own prescriptions, but only after you've made them in the first place. So, of course, we want to help people come off medication, and of course, we want to offer people alternatives to medication, but that's it. We get people off medication by having a conversation with the people who do the prescription, and both, you know, the British Psychological Society and our medical colleagues support that, and we offer alternatives. Now, I can see an argument for whereby, A, as part of a formulation, you want to get involved with a discussion about an alternative regime of medication, or for introducing the kinds of tapering streaks, the hyperbolic reduction in dosage that Mark Horowitz and others talk about, whereby specific conversations with a dispensing pharmacist are necessary in order to help people go through the complex hyperbolic curve to get people off these very powerful drugs. And in that conversation, I can see why in those circumstances, you might get frustrated. You might get frustrated because a particular form of medication, a particular way of presenting the medication would fit in with the curve. And I can see the argument for saying, if the people around you are refusing to engage with that plan, maybe you as a prescribing psychologist could issue a script for a tapering strip anyway. If that were to be the case, and if it were to be the case that the prescribing physician, the one whose drugs you want to help the patient come off, is refusing to change their prescription, you've got a whole other set of problems there that having prescribing privileges simply aren't going to solve. And I would remind you, the legislation that we're talking about is supposed to give psychologists the right to give prescriptions only in the context of a multidisciplinary team. So if that one limited circumstance were to pertain, where you couldn't have the conversations that you should have, and where you couldn't offer the alternatives that you're supposed to offer, and in fact, the only alternative is to disregard the prescribing practices of your colleagues, again, what I say is we're in a whole world of pain that's got nothing to do with the rights of psychologists.
Rebecca, what about the idea of just engaging with colleagues and talking to them about how it might be a good idea, if the client agrees, to start tapering their medication rather than needing to be able to prescribe it yourself? Can you not have those conversations, or is it that you'll be taken more seriously in them if you have prescribing rights yourself?
I think we do have those conversations. I mean, certainly in my professional practice, we work very closely and collegially in a multidisciplinary team, and certainly as a non-medical responsible clinician, you kind of need to do that. But You know, for example, you might have somebody who you are looking after who has a cardex, and actually there's something that needs to be stopped immediately because there's a very severe side effect. And at the moment, you have to go and find a psychiatrist or somebody to come and take it off, and just taking it off right then. What Peter says is actually factually incorrect. It is true that as supplementary prescribers, you have to ask the person who did the initial prescription in order to reduce or stop it. As an independent prescriber, you do not have to ask the person who initially wrote the prescription, just so we can be absolutely clear. And that is how it works with all existing professions already.
Okay,
However,
could you come back very briefly on that, Peter, because I want to put something to Cheryl as well.
So my answer is that...
What I would say, however, Peter, is that you would, given that we work collegially with our colleagues in a multidisciplinary team, you would normally talk to your other members of your team around things. So if I was seeing somebody and I wanted to reduce the medication, for example, if it was me, I might go and talk to the psychiatrist team and said, actually, you know, you do medication review, and you might see that things have changed in the past, and you might get in touch with a previous prescriber and say, actually, can you tell me why that was stopped or that was started, and get a bit of a background rationale. It's about working collegially and being a team player. It's not about having to do what another profession tells you to do. I mean,
so I'd like to come to Peter very briefly on that precise point about whether they can or can't change the medication, because I really want to come to Cheryl.
Well, I've heard a different story. So I've heard a story from members of this working group that have said that if the multidisciplinary team, including the dispensing pharmacists, already have protocols for listening to other prescribers and changing the scripts for patients, if those circumstances pertain, which is the have a conversation with your colleagues point, then any member of the team that have been approved as being a prescription changer can change prescriptions. The point about that is it's a conversation with the team. What I've heard from both GPs and psychiatrists who I've asked about this is the respondents that have commented to me have said, no, I don't think any doctor can change another doctor's prescription. It just doesn't work that way. What happens is Doctor 1 issues a prescription, Doctor 2 issues a different prescription, and the patient ignores prescription 1. So, Rebecca and I have heard different data about this. And from the point of view of the BPS, there's a reason for concern, in my view.
Fair enough. We have to disagree on that one. Cheryl, I wanted to come to you because I thought it's interesting, this point that Rebecca brought up, which I know has come up before about people sometimes having to wait if you see a psychologist and then that psychologist can't prescribe and some sort of prescription needs to be changed or added or whatever it is, that then people might have to wait to see a psychiatrist as well. And that also sometimes people had to tell their stories more than once. And I was wondering whether this is something you have views or experience of or views on about, this idea of waiting or delays or telling your story more than once.
Yeah, my friend was in the army, and he went to Afghanistan and Iraq and came back a different person. And he was a mess, and he had to see a psychologist. And because the psychologist wasn't allowed to prescribe him anything there and then, and he had to wait for a psychiatrist, he went off the rails, we'll just say that. And it was very, very sad to see. And if the psychologist had had the prescribing rights, we do feel that things would have been different. And I would just like to pick up on what Peter was saying before about, for me, the reason why I would like to have a psychologist rather than a psychiatrist, it's not necessarily just because they can de-prescribe. It's because they would understand me better. In my opinion, they would understand me better because it's a more holistic therapeutic approach. And it's not necessarily that they're going to de-prescribe or prescribe. It's the fact they would have the knowledge of that. They would have the capability of understanding the medicines from the psychiatrist, or what's available or what has been available that possibly isn't helping And because it's a psychologist, they would understand how that person's working slightly better, and perhaps a different medicine would work better. It's not to say that the psychiatrist doesn't know what they're talking about or the psychologist doesn't. I think it's just a different mindset. And I think it should be more to the patient who would be able to make the decision of who they would rather prescribe medicines for. Or the best case possible is everyone actually talk to each other. The psychiatrist and psychologist work together as a team.
Thank you for that, and sorry to hear about your friends and that story. We've got a couple more questions that have come in. Just a quick one, Rebecca, that I think you'll know the answer to. If psychologists undertake the training and prescribe one day in the future, would they get paid more than psychologists who couldn't prescribe?
I think that's a really good question, and the answer is I don't know. I think what I would say is that you know, it's the same for any profession, and one of the things that I've certainly been faced with in my career recently is that we have, as a profession, we've given away a lot of skills. We now have a lot of people trained who are not psychologists in psychological models like CBT and other single therapy models, very competent in formulation. And I myself have been faced in a position where when you know, managers who are holding purse strings are looking at replacing posts, they're saying, well, we can get a nurse consultant to an 8B who can be a non-medical responsible clinician. They can prescribe, they're skilled in therapies and formulation. So why do we need a psychologist that is more expensive than that profession? So
if you did go down this route, could it not then, and people, psychologists, no one would have to do it, they could choose whether to do it, but could that then put those at a disadvantage who didn't want to do it?
I think what I say is a bit like the non-medical ACRC role. It's not paid at a specific level. So we haven't seen a change in that. And consultant grade posts are still paid as consultant grade posts. You don't get paid any more to be a non-medical responsible clinician. And this is a very similar role in that it takes about 2 years to qualify. You have to have formal authorization through an approvals panel for the Mental Health Act. So I would say based on that, I would say actually it shouldn't make a difference. But my worry is more that actually, you know, there is actually a risk that if we didn't, I guess that psychologists would just be seen within their remit of doing psychological therapies and formulation, and then other professions would be seen as being able to do more than we can, and actually, and for less money, because we are quite an expensive profession. So I think there are pros and cons, and there are risks, and we can't anticipate the future.
Elaine, I've got a question to put to you that's come through from somebody watching, and thank you for keep sending in such good questions. Psychologists who prescribe will need to give a diagnosis. Isn't this a threat to formulation? Isn't it forcing psychologists to diagnose in the way that psychiatrists might?
I don't think so. I haven't experienced it that way at all. You know, maybe, I don't know how it works for you. Yeah, I have to put some kind of diagnosis down for the insurance to pay. And, you know, they can be guideposts, but I still look at each person as an individual. And in response to this, if I could just add on a little bit, you were asking me about a case, and it just came to my mind. I've been seeing a woman that's in her 70s, and when she first came to see me, she couldn't even walk without holding on to, you know, a walker. She looked like she was about 110, and she was on 2 different antipsychotics at a very high dose, about 4 or 5 different medications. And the prescriber, every time she went in and said to this prescriber, "I'm feeling anxious," he upped the medication. Well, this is where you need to be able to do both things. So while I'm helping her address her anxiety, we started whittling away. We didn't, just very, very slowly, on one medication then the other. It took over a year to get her off of those medications, that she was so sedated that she was only up about 6 hours during the whole day. And now she's really fully functional and she's on one medication. But I don't see how I could have worked with somebody to do something that was that complicated and delicate. You know, it's like trying to separate an operation that takes both pieces, seeing the person as an individual, as well as knowing how to, you know, a titration schedule.
Thank you for that example there. And Peter, briefly, it is the case, isn't it, on this diagnosis question, psychologists vary on how much they use diagnosis and how much they don't. So isn't it the case that many, you know, do that anyway, even if it's just that the computer requires them to put something in? So why would it change what they do?
Oh, sure. But I mean, we're talking here about a psychological perspective on the care of people whose problems in their lives lead to a challenge in their mental health. And, you know, I'm on record, I've got papers about how, as well as quasi-medical diagnoses such as major depressive disorder or schizophrenia or personality disorder, the World Health Organization, and for that matter DSM-5, allow us to use phenomenological codes and social determinant codes. I've got a paper, hopefully it's coming out, it's kind of on the borderline of acceptance, which talks about the fact that in 0.03% of cases do clinicians actually use codes that are non-medical, that are available to them for quasi-diagnostic purposes. And indeed, I can't remember quite how many people you looked at with a diagnosis of supposed post-traumatic stress disorder, i.e. a diagnosis which quintessentially results from my stress. And on not one single occasion did the clinician actually put down in the medical records what the event was that has supposedly caused this post-traumatic stress. So part of my argument is we need to move away from diagnosis. And I mean, I think so yes, some psychologists use diagnosis. My personal view is that we should use other ways of recording people's distress other than diagnosis for the reasons that we've gone into. And this debate, as Schafstein said in his presidential address to the American Psychiatric Association, this route takes us down the bio model of mental health care. It's unfortunate. So you're right, some psychologists use diagnosis. You're right that in America, because of the way that the healthcare system is predicated, it's a requirement. It's actually not correct that you need to use the quasi-medical diagnosis. You can use other legitimate ICD codes, phenomenological codes and others. So all of that's possible, and part of our argument here is, please, let's move in that direction. I think it's interesting that your question to Elaine was, Elaine, does this take you in the diagnostic direction? And Elaine's response was, no, but of course I diagnose everybody. And that's exactly the point. If we take this categorical view of human nature, if we take the idea of this essentialist view of human nature, that there exist things called disorders that people have that cause problems, rather than the labels of disorders are labels that we choose to apply to normal human psychological distress. If we go down that route, it does take us down the route of essentializing the problem, reifying the problem, rendering the problem to be a dysfunction of the biology of the individual that should be put right with medication. So I think the diagnosis argument and the medication argument are hand in hand. It's interesting that in the discussion document that the BPS is producing, that is part of the essential requirements, is that diagnosis is the prelude to medication. Once you've gone down that route, I think that you've taken a retrograde step. And I think it's interesting that your question to Elaine was, does it lead to diagnosis? And her response was no, but yes.
And Rebecca, I'd like to put this diagnosis question to you. So isn't it inevitable that you will then have to go down the diagnosis route if you are prescribing?
Okay, thank you very much. I think it's certainly a hot topic in itself around this. And for clarity, the diagram in the document says, you know, you listen to a person's lived experience, and then formulation and diagnosis go side by side, and then underneath it says thinking about a range of treatments. What I would say is at the moment our diagnosis policy and guidance document within the BPS actually advocates that psychologists may use diagnosis if they choose. I'm aware that there is a movement to move away from that, which has many positives. But I think the main thing is actually, you know, a lot of those are driven by us moving away from, you know, what's wrong to hearing about what has happened to the person. And I don't think that needing to use diagnosis necessarily takes away from that automatically. However, what I would say is that at the moment, all of the systems for prescribing medication are all based on a diagnostic system. So all the contraindications and all of those things are based on that. And I remember going with something at a BPS conference where the Power Threat Meaning Framework authors were actually talking about it. And I actually asked out interest. I said to Mary Ball, I said, is this kind of framework adverse to medication? It was a large audience, about 150 people. And she said, no, it isn't, because I actually pointed out actually that's problematic on the basis that Peter mentions. What I would say also is that I'm a big believer that change comes from within, and I know from colleagues in the United States that since they are now prescribers, and Elaine might want to add to this, they found that they are now having greater influence about thinking about medications and things like that at that higher level. I suppose for me, you know, if you have this skill, theoretically, you could actually do some really good research where you have service users that might have a diagnosis and they might have a formulation and work together and have prescribing. And then you might be able to compare the two to say, actually, can we get away from this taxonomy? How can we do this? Can we prescribe without it? But we're not in a position to do that because we haven't got the necessary competencies to at the moment, because we're not prescribers and we lack that knowledge.
And we are rapidly running out of time, but there's one question I'd like to put to Elaine and I would like to end with Cheryl. Elaine, we have a question saying, is there a way that you can use your prescribing to avoid over-prescribing? You know, use your powers to prescribe to avoid over-prescribing, and how can you do that?
I think it's inherent in our training that we will think about all the ways we can help somebody, not just prescribe to a symptom, like in the example I gave you. And in the process of doing that, we tend to use less medications. We have some research that the prescribing psychologists are much less likely to use multiple medications than some other prescribing professionals do. And I think the question the person is asking is the reason why it's so important that we be involved with this, because our training allows us to do that.
Thank you for that. And Cheryl, I know that the consultation is open for another week on this. And I'm interested from your perspective, what would you like people to bear in mind in their discussions about this in order to make sure that clients, service users are at the center of what's happening, and that the decisions that are taken are what will be best for them and that they're listened to?
I think the most important thing is to definitely listen to service users and try and get more answers from them. And I know we had a big group initially that was talked to about it, and then unfortunately a lot of people ended up dropping out. So it is quite hard to get the base kind of level of service users. But I'm not sure about in the other parts of the country, but I know in the northeast area. It is such an important decision that it's not something that can be rushed, and this has been a good few years in the making. And it's something that is obviously always going to be looked back upon, but I think it's an important decision and an important step forward to help people, yes, reduce the medicines that they're on, but also to help people possibly go onto medicines that they might not have been given unless they'd had a psychologist talk to them to know what would suit them better. And it's just such an important decision, and it needs to be really looked at and really thought about from lots of people's different points of view, and to try and be very open-minded about it.
Thank you for that. Some wise words there about looking from lots of perspectives. Thank you very much, Cheryl, Elaine, Peter and Rebecca. Now, it's very clear that people do have varied views on this, and that I don't know, it seems some of the main issues seem to be about the role of psychologists, whether it will change their identity, whether it sends psychologists more in the direction of a medical model or not, or whether it could do the opposite and allow more alternatives to be offered. And it also sounds as though this could vary on the setting that people are in as well, making it harder to generalize against all settings. What has been really nice hearing people talk today is that people, I think, have very much been putting the client at the center of things. Now, the BPS has just a few hours ago had results in from a YouGov poll, which is on the people from the general public. It was a representative sample of 2,070 people on whether or not psychologists should have prescribing rights. And this is the first time I'm seeing these results, quite interesting. The main findings were, so these are very hot off the press, 46% of respondents support psychologists having the right to prescribe, 15% oppose it, 26% neither support nor oppose, 13% don't know. Interestingly, 18%, 1/8, thought that psychologists could already prescribe. Now, the main reason people gave if they supported it was that they wouldn't have to see more than one person. The main reason people gave against it was that they said that it's doctors who should prescribe and not psychologists. So interesting range of views there as well. So thank you very much, everybody who's been listening, and thank you so much for all your really good questions as well, which were really interesting. I think it's a fascinating subject. But let me hand back to Alison Clark, who is going to round things off for us. Thank you.
There you go. I finally hit all of the right buttons, it would appear. So I have nothing to say to round things off in terms of summing up the content, because that is absolutely not my function. We have Claudia there to do that great job. So I'm just here to say my thanks to everybody for participating so attentively. My thanks to everybody out there in Zoom land who've been feeding in all of the questions, and to each of the panel who have been answering all the questions. My final invitation is to urge those of you who are out there in Zoom land who have something that you'd like to add to the information that we've been gathering up, to check your emails. You'll get a link to the Society webpage with all of the information on it that's assembled already, and you'll get the email address to give us your further comments, and just know that they'll be as welcome as everything we've had thus far. I think it's going to be a mighty challenge to weigh everything. It's exceedingly close, it would appear, and I don't envy the work of those people that are going to have to complete the recommendations that we will be having to complete, whatever they turn out to be. So thanks to everyone. I see a little note to me from somebody at the moment. I'm just checking all Slido. Oh, there you go. All Slido comments and questions will be saved to form part of the evidence, and with apologies we couldn't get to all of them. So thanks to Hannah for that note, and thanks to all of you for participating, and thanks to you in the chair, Claudia, for making it all work so well.